Effective January 2026, the organization has initiated formal tracking of reported verbal threats, physical threats, and incidences of escalating violent behavior. To date, we have 6 incidences that have been reported. 3 include visitor on employee altercations, and 3 include patient on employee altercations. Of those 6, 5 were physical and 1 was verbal. In response to these events, leadership is in the process of implementing some additional security measures aimed at enhancing the safety of our patients, our visitors, and our staff.
That's good. All right. We good to go now?
Yeah, we're fine.
All right. So we do have a quorum. Ted, would you lead us in the pledge, and Anna, would you lead us in prayer, please?
Yep.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Lord, I thank you for today, and I thank you for this hospital. I just pray that you would give us wisdom and insight, and just ask you for help in not only finding a permanent CEO, but also just help, and just ask you for help. Thank you for that. It's in your name we pray.
Amen.
Okay. Oh, thank you. So I know we do have Ted requested a change to the agenda. He's got some public comments he would like to share. And I believe it works if we add that after the approval of minutes, if that's okay with Ted. Great. Okay. Do we have any other changes to the additions to the agenda or changes? Not. Take a motion to approve the agenda as with the addition of Ted's public comments after the minutes.
So moved.
Maybe a second.
I'll second.
All right, moving second. All in favor? Any discussion? All in favor?
Aye.
Aye.
Opposed, say passes. Okay, so moving quickly. We have a chance to read the minutes for May 21st, which was a normal meeting, and then we have the May 26th special board meeting. We all get a chance to read them. Any changes to the minutes as they been written? Pardon? No? I'll take a motion to approve the minutes as written.
I so moved, Mr. Chair.
Okay. In second. Any discussion, further discussion on the approval? All those in favor of approving the minutes as written, say aye.
Aye.
Those opposed, same. Okay. Minutes passed. Let me sign real quick and I'll pass it to Barry. All right, Ted.
Mr. Chair, I had several people either call me or stop me on the street. I'm just going to run down through these real quickly. One of the comments was during our last meeting, they was talking about the some of the high school help that had was help feeding the older. I think part of their comments or the in the manor. One of the comments was that they did have some training, that the registered nurse had trained him, and now whether they had enough, I have no idea. But they had been taught the Heimlich maneuver type training. And also the next comment was that some of these individuals, it was a great chance to see whether they would like after they graduated out of high school, that type of job. And I understand that, you know, it takes a special person. How would you know unless you've been there, done that? Whether you want to go on and have further training in that. One individual, jumping subjects in the Manor. We've got an outside doctor coming in doing a foot clinic, and was told, now this is word of mouth. I'm probably the third person, so I don't know all the facts, but they've been receiving bills from that clinic. Now, if they had work, I understand receiving a bill, but Medicare or Medicaid they were told when they give permission for their family member to have that, that it was going to be paid for by Medicaid. They've been receiving, and some sound like what I was told, some of the bills were pretty high. Now, I'm just passing that on as hearsay. The other, quite a lengthy conversation on burnout. And we talked about that in the Manor, that burnout is when someone doesn't show up, call somebody else in. It seems like the same individuals get called because they show up, and it's they're feeling a burnout because they're there, finally get a day off, and then they're called back, or may not be called back, or feel that they're going to get called back. That burnout is, they're worried about, they feel that they're good individuals getting called back, and we don't want to burn those individuals out and lose them. Another comment was that they felt that there should be three, for lack of a better term, people during the evening helping out. A bath aide, there was a bath aide in there the other night. They said that individual really helped because there was two staffed, and they think that it would take 3 staff or a bath maid and 3 staff, I don't know, and then 4 during the day at night. So that was my comment. Yes, several different individuals kind of rolled in one.
I have an individual talk to me too, mostly talking about needing more. 2 issues that he talked to me about mostly was the Manor and feeling like they needed more nurses, and then also when there's another issue that I think we'd better to talk about.
Okay. Would you like to address any of that?
Yeah, I was gonna say, Kim can help me and Trissa can help. Also, if I miss one, you'll remind me, okay? With regard to the dietary clinic or the foot clinic, if you can talk to us offline, Ted, and give us a patient name, that would be helpful. We don't do the billing for them, but we can talk to them and say, we heard from this patient, please call, what's happening, and we can be that conduit to help resolve.
Okay.
Okay, so if we could get that offline. With regard to some of the Manor pieces, and Kim jump in. First, we don't want our staff to burn out either. And so you'll hear throughout this meeting today, the recruitment activities we have are completing, continuing to complete, and the number of hires we've made. Our goal is not to have any agency staff, and we've made great inroads. And I agree, and we'll explain to you what we have done since we last met together. Staffing during the day at the Manor, there are 4 CNAs. Okay, and staffing in the evening
Is 3.
at night is 3.
Okay.
That being said, you also hear about again today, so I hate to bore you again, that we have posted, in addition to that number of staff, a bath aid from 5 a.m. to 1:30 p.m. 7 days a week. And so And that was based upon feedback since our last meeting. It started before our last meeting of the board, and then subsequent meetings after that with feedback from the staff and others to go with that bath aid. And so that's part of our solution too, and we'll talk more about it. What am I missing? What did I miss, Ted?
The comment about I'm going to call them high school.
Oh, yeah. So I'm going to do my best.
Yeah.
You jump in. So the NSAs did have training. They had an 8-hour certificate for nutritional support aid training, and I don't doubt, I agree that they had the Heimlich and what have you. What they're not trained to do, unlike a CNA, is to feed patients or assist in feeding residents who have swallowing issues and problems. And so what we have done is normally we've had 2 MSAs in the dining room. And because of where we need to go as we all age, myself included, and sometimes some swallowing problems are undiagnosed, we have 2 CNAs now in the dining room helping feed patients, the main dining room, instead of NSAs, and we've staggered the CNAs breaks and lunches to allow them to be in there with the residents, so the residents actually have a higher level trained staff member helping to assist them through the meals. And then the other CNAs, 2 others are helping pay residents with trays in their own rooms that do not wish to come out, and then also on the memory unit.
Dedicated.
She trained me well.
Can I ask a question? And I know you can't speak for them, but when they're talking about burning and getting called in, or burnout and getting called in on their days off, do they feel obligated that they have to come in then? Or, I mean, can they just say no?
The individual that I talked to, I think they have feels ownership into the Manor individuals, that they feel that if they don't come in, they don't want them short-staffed to not have what they need. Yeah, I think they feel that they should come in and need to come in. Now, whether they do all the time, I have no idea. And I don't know how often this happens. I know days off are important for everybody. And some people are more flexible than others. It depends on what your family's got planned or kids at home and things like that. How much hardship dropping your plans and coming in. I can't answer. Really
But they don't feel threatened, hopefully, that.
I don't think they feel threatened.
Just feel responsible.
It's, yes, responsibility, ownership into providing service.
It looks like she has an issue.
We did go through a period of some high call-off times, but we have kind of an initiative to help get the shifts covered. And with the call-off piece that I'll talk about a little bit more later.
Okay, all right. There were just comments come to me, and I wanted to.
Are we tracking a call out rate, or do you guys track that? I mean, not.
We're tracking call-offs, yes.
Okay.
I just, need to bring it before. And it sounds like you're addressing some of these already, or have addressed these already. So
Appreciate that, Ted. Any other comments? All right. Moving into a change in a proposed change to the July meeting. So there's a couple reasons that I'm proposing this. One of them is going to be a requirement to get the budget approval done. We couldn't do it today. And so we'll need to get that done obviously before the second week of July, third week of July. Okay. And from my standpoint, I am gone 2 weeks out of July and won't be back until the 28th. Well, I'll be back before that, but I would be available for Thursday the 28th, but that'll be too late. So I'm proposing that we change the same time to the Thursday, July the 9th, to have our next regular board meeting and budget approval at the public presentation of the budget at 5, and then the regular meeting at 5:30. Go ahead, Karen.
So the only concern that I have, and Paul could probably jump in better than me, is that getting financials out for the month by the 9th will be very, very tough, if not. I hate to say impossible, because Paul's kind of a rock star, but
It's gonna be tight because it's
It'll be
year end,
tight.
it's also year end, right, Paul?
Yeah, that's exactly correct. So we're reconciling the entire year. We have to hit another timeline as well for the FY26 audit. It is going to be a tight turnaround time.
So would it be possible to just send those out at a later time, separate from the meeting, and they'll be discussed in the August meeting? Is that possible?
if that's fine with everyone, as long as we set that expectation.
Yeah.
Is that okay with you, Paul?
Just so I'm clear, we're saying front load the budget and then wait for the rest? Or what do we,
So we'll
I
have
didn't quite understand.
meeting, the regular monthly meeting will be moved to July 9th, and it will include the budget presentation, but it will not include financials for June.
That'll work.
And so we can do, and you can send them out or advise that they're available, but we'll really discuss them then in the August meeting, June and July. That works.
Yes, sir. That could work.
All right. So I guess I would look for a motion, or I guess I can't do the motion myself.
How does that work then for the quality meeting then? Will that be?
The quality meeting's the second Wednesday of the month.
So it'll just be the day before.
It'll be the day before.
And your finance meeting could just stay the regular date.
Yeah, so I was gonna ask that if it's okay with the board and finance committee and Paul, maybe we just keep finance committee at the, what would it be, the 21st? Or would it be, it's kind of a weird, right?
That-
Would be the 14th.
The-
It's the day.
Right, so would you rather do finance committee either the 14th or the 21st?
July, we're talking, correct? Yeah. Okay. The 21st is fine. Either one actually works. We have to submit the financials on the 27th. So any time is fine for that. Those 2
I
days.
won't be well on the.
So is finance committee will just meet on the 21st and go over the finance?
And that's our schedule.
Everyone?
That's what's already scheduled.
Well, it wouldn't be, but I
It would
can
be
change
on the
it.
14th.
Yeah, but we could change it just for the
21st would be the.
So it's because of the way the month falls, the third Thursday is the 16th, but that's only the second Tuesday. Yeah.
I'm just saying on
So
my
it does fall that way.
Yeah.
calendar is the 21st. On my
Okay.
calendar, that's what's confusing.
Okay.
Okay.
So with that, is that okay with finance committee, Paul, Pat?
21st.
Let it rock. Okay. Thank you.
So I can make a motion probably.
Thank you.
I move that we hold our July meeting on July 9th with a 5:00 budget presentation, and then the regular meeting to start at 5:30, and also including the finance committee meeting in July 21st.
I second that.
Any discussion? All in favor, please say aye. All the same? Okay, passes. Thank you all, appreciate that. Helpful. All right, visitor comments. Do we have any visitor comments? No visitor comments?
Just want to know how we're coming.
Excellent, you're welcome to be here. Okay, Then we will move on from Mr. Comments into our reports. Quality starts. Paula.
Chairman Roberts and board members, good evening. I'll be providing you a brief overview of the patient safety and quality highlights from Weston Health Services. For the infection prevention, surveillance is ongoing in long-term care, emergency department, and acute care with no reported outbreaks. I've been working with our maintenance manager, Ron, and long-term care director, Kim, on plans to replace the existing memory care unit flooring, making sure that we're maintaining compliance with all of the state and federal regulations, as well as life safety codes and infection control policies and guidelines. For employee health and safety, workers' compensation claims year to date of 6 compared to 9 this time last year. So we're down a little bit, which is good. Lost time from work is 0 days. Effective January 2026, the organization has initiated formal tracking of reported verbal threats, physical threats, and incidences of escalating violent behavior. To date, we have 6 incidences that have been reported. 3 include visitor on employee altercations, and 3 include patient on employee altercations. Of those 6, 5 were physical and 1 was verbal. In response to these events, leadership is in the process of implementing some additional security measures aimed at enhancing the safety of our patients, our visitors, and our staff. And they'll go more into detail in a bit. For quality data, interfacility transfers for May are holding steady with April's numbers for a total of 15, with 10 going by ground ambulance, 3 going by flight, and 2 going by private vehicle. Manor transfers to the emergency department increased by 50% from the previous month, rising from 5 transfers in April to 10 in May, with a total of 3 admissions to our acute care floor. So, discharge readmissions within 72 hours totaled 6 for the month, which has held steady with April's numbers. We had a total of 3 witnessed falls, 2 in acute care and 1 in physical therapy, with none of the patients sustaining any injuries. So that's a good thing. And there were no reported pressure injuries in acute care. For compliance risk and regulatory, no word back from the state or the feds regarding our EMTALA review. Denalda did inquire with the state on the status, and they reported that it is still under investigation. So no reported patient complaints or grievances, and no compliance hotline issues, and no HIPAA privacy issues to report. That's it. Do you have any questions for me?
Thank you, Paul.
Thank you very much, you guys.
Thanks, Paula.
Yep.
Kim.
So our current census today is 46. We did have a decrease from last month. We did have some discharges due to death, and then we did discharge 1 to an assisted living facility. So, like I said, we're at 46 right now. Our hours per resident day for May was 2.73, and so just a reminder, the Wyoming state minimum is 1.5, so we're still exceeding that 1.5. Even with our call-offs, we're exceeding that. Our agency utilization, we have 6 agency staff right now. We've got 3 CNAs and 3 nurses. Our highest that we have been was 13 CNAs at one time and 6 nurses, so we're considerably down from there. Open positions, we had 5 at the time I did my report. However, 2 of them onboarded today, taking us down to 3. We did interview another CNA yesterday, and we decided we were going to offer her a position. So she came on board as well. So that'll take us down to 2 open positions. We also are recruiting for the bath aide. We have a potential interested candidate in that, so that'll help out significantly on the floor.
So how is it 3 open position, and how many agency do we have?
We have 6, 3 nurses and 3 CNAs.
But we're down from
13.
Right. So how come that we don't have 6 open positions?
We originally started with 7. So as we are hiring more with 1, we will be reducing the agency staff.
Mm-hmm.
Okay.
Yeah.
you have to orient people.
Okay.
So you have to have
that's
some
the-
overlap.
There's gonna
Okay.
be a little bit of
It's the
overlap,
overlap.
and then we'll start
Okay.
noticing.
That's what I was trying to figure out. Okay.
Yeah.
Thank you.
We are also recruiting for director of nursing. We had two really good candidates apply. We had one internally and then one externally. She's also from Wyoming, so we've interviewed them. We had an interview panel that consisted of me, Donalda, Holly, Pat, Rebecca. Dr. Haverly wasn't able to attend in that interview, so we're just waiting for him to make contact with them, and after that we'll make a decision on which one. So that'll be coming here. Hopefully I'll have a more good news next meeting. Recruitment and retention efforts, I kind of touched on it a little bit earlier. We started this temporary initiative, I like to call it the blue light special, for staff as we kind of get over this hump of getting these new CNAs in and trained. We had some open positions that needed to be filled. So we gave them the shift incentive plan, but if they picked up 3 additional shifts within that month, with no call-offs, that was kind of the big caveat, no call-offs, and you do 3 additional shifts, you would get $1,000 bonus at the end of the month. So that's been received pretty well. Staff are picking up. The schedule's getting a lot better. So that'll pay out, I believe, the July 17th paycheck. So hopefully we'll see a lot of staff happy come the middle of July. And we're Christmas in July. We're working on community outreach and financial planning. We're exploring opportunities to offer educational seminars to the community that'll focus on financial planning and long-term preparation. It'll include information for families on asset preservation, trust, Medicaid eligibility requirements to help these families kind of prepare and proactively plan for future long-term care needs. We have a lot of ranchers in the community, so how can we help them in the future? So we'll be looking into that. And then just on our quality indicators, today we've only had 2 falls in June, so that was really good. We had 16 we ended up with in May. Skin integrity, so far we've got 1 skin tear reported compared to 2 skin related issues in May. We do currently have 5 residents that are being followed by the Wound Care of Wyoming, so they come every other week and we'll do wound care and measure and see how we're doing. We do have 1 that is healing, that they no longer need to see. Call light times for June to date were 13 minutes and 44 seconds compared to 13 minutes and 29 seconds in May. Response time data is slightly affected by one of our residents. He won't allow you to turn the call light off until the nurse has come in themselves as well. So that is kind of impacting the call light time, kind of skewing it a little bit. And then total call lights to date in June, I was only able to run June so far, was 2,336 call light activations that the staff have answered. So that's about 146 per day, and that's looking to be about a normal average. So, yeah.
Thank you. What we're gonna do is, bring that, cause you say, well, how many call bell lights are people at? Like, give me a benchmark, give me an idea. So we'll bring that continuously to the meeting and start tracking it and understanding, tracking the call bell light percentage, timing. It comes off the system, but we also are together as a team watching and supporting each other with our team to answer the call bell lights more timely and with the system.
146 per day, so that's 6 an hour. It's a lot. Wow.
What would be considered the standard for time? What would be the benchmark, I guess?
The benchmark is about 5 to 7 minutes, so we're a little bit above that. Yeah.
How's the whole bathroom situation? Is it getting better?
How's the bathroom situation in terms of what, after getting to the bathroom?
Last week.
I can put a specific bathroom call light time. I can bring that information next month if you would like, or email it out.
I just was curious when it felt like it was getting better.
In your rounding, have residents brought up concerns related to being left in the bathroom alone, not answering call
I've
bell
heard
lights?
any concerns brought up about being left in the bathroom. Her staff work super hard. That's really amazing. Yep. That's all I have for you.
Okay, thank you.
Thank you.
Yes, you have the clinic? Thank you.
Okay, I'm gonna report on clinic operations as well as the revenue cycle today. Our current temporary, United States temporary 2 model is holding steady. Right now, we are got 6 applications that we're reviewing with Dr. Haverly. He's narrowed it down to 2 that he would like to interview for that position, which are 2 really good candidates that are in this area already. Our volumes for the month of May were 368 with the 2 practitioner model, temporary. In the month of May for 2025, we did see 518, so that's down about 150. We are now booking out to July 15th. That's how full we are. Dr. Haverly is seeing about 18 scheduled patients on the days that he's here, Monday through Wednesday, and we have been seeing 12 to 16 walk-ins per day, which is up from what we had been seeing in walk-ins. We are currently in the process of coordinating our July sports physicals, which will be free. We are working to do a later appointment in the evening as well as a Saturday appointment to help parents not have to take off work and to be able to schedule those at their leisure in the evenings as well. We have been experiencing some technical difficulties with our air conditioner at the clinic. Just so that you know, the system has failed. The furnace did fail last year. The air conditioner is on its very last breathing air that it's going to have. Ron has gotten some quotes for me, and we will be working with Paul to see which is going to be important. We have that as well as our vaccine fridge that stores our state vaccines downstairs that have been setting off alarms because of this air conditioner failing on that side of the clinic. It gets very hot. It has no air. And it's just, it's aging. That was donated to us from the state, just so you know. When we have quotes for those at the same time, and then we'll work that into this budget for this next year. Right now, our vaccine has just been moved upstairs to our main fridge, which makes it just a little bit full, but we're managing.
This place is full of love. You can tell the people that like to be with old people because they really take care of you good and are very kind.
Twice a day, every day, the activities people have an organized activity that's always interesting.
Everybody loves to play bingo. We play it 3 times a week here. We also have ceramics that you can paint. Really pleasant to live here. It's a good place to be.
That we have installed a new door lock system. If you've been over to the clinic, it's just for an enhanced protection against healthcare workers. So when you arrive at the clinic, you wait out in the main lobby area, you push a door bell alarm, and then there's a mirror that allows people to see who's coming, who's leaving, and then they push a button. And so it's making a good presentation in our community that we're protecting everyone that walks through our door. Amanda Lesmeister returns, and I'm so grateful that she's coming back. She will be returning from FMLA on the 13th of July, so we're very excited to have her return. I'm just excited that we don't have to cover for her. I'm sorry?
She's a super cute baby.
Oh, she's the one. Yes, I do still her quite a bit when she does come in. As far as that's about all that's been going on for the clinic, does anybody have any questions that I can answer? None? All the move into revenue cycle. This month has been very productive. We are seeing continuing working on the queue volumes, and when I say queues, these are better if a claim comes back from our scrubbing system, it falls into rules, and those rules then separate them out into different queues that are worked for different reasons. Every queue has a commercial, Blue Cross and Blue Shield, Medicare, and Medicaid. So upon the reviewing of all of these, there was a lot of information that was stuck in there and has been stuck in there for quite some time. We have been focusing with the ANOVA group that we meet twice a week on regular meetings, and then every morning we're meeting with them for a 15-minute call to get them scheduled and get them outlined in what we need to have worked for that particular day, and it has been going very well. We do have quite a few bad debt accounts, and when I say bad debt, these are basically accounts that are self-pay. They have been sitting waiting for payment from and they're not just people that don't have insurance. These are people that had insurance. This is a balance that's theirs to pay, and they have just refused to pay it. So what's happening before the 30th of June, Paul and I are reviewing the spreadsheet right now. If they're on an active payment plan, they won't be sent to a collection company. But if they have not made a payment and the account is truly bad debt, it will be turned over to our collection service. It's about $1.4 million. We have been working on our process improvements, and our initiatives focus on increasing patient awareness, service costs, and financial transparency and prior to care delivery. And that kind of goes back to we're getting a lot of calls right now with people calling and asking questions why they're receiving an explanation of benefits. They just want to know why their insurance isn't paying. Is it going to deductibles? Was it medical necessity? So I field about anywhere from 12 to 20 calls of those every single day. We are really trying to educate and explaining, giving them options, letting them know what to ask, what not to ask with their next visits. We are also having that, one of the things that we have discovered just even this last week is we're not utilizing our Epic system to its full potential. There are systems inside of Epic that allows us to send text messages when it does turn to self-pay. Those are not turned on right now, so we're going to implement those. It comes through what they call Hello World, My Epic. So when a patient receives a balance, it will send a text message, and then it will also go into my chart that says you do have a balance with Weston County. So we're going to implement those. Hopefully come July, we will see a really good increase of people being aware of that. It will also log that they're going to be having that balance. There is a new regulation from CMS that enacts on June 29th, and we were ahead of that already, where we have to report the NPI on each line item, just so that you're aware. So any professional billing, a provider receives you in your room, we send that out on a professional bill. Their NPI number has to be on that line item. Epic is working with us with our analysts, and we're way ahead of that, and we should be deployed probably within the next couple of days. So we are in compliance that way. Any question on revenue? We are doing a great job with collections. As of right now, we've brought in almost close to a little over $900,000 for this month already. For the specialty clinic, which I've now inherited as well, just working on contracts, trying to get some more outreach going, making sure that we're listening to our community, trying to get some more providers in that will service those needs. It's been well received, just trying to get some other information out. So,
are there anything being implemented new in the clinic as far as expectation of people that you're seeing now that are self-pay?
Not necessarily.
Any changes?
We're just trying to offer those programs when they are self-pay, letting them know. We will be rolling out a new policy that you will all probably receive in the month of July, if we can get it typed up and ready to go. We're just going to try to mirror basically Medicaid rates, and then Paul's got a really good self-pay financial assistance policy that he's going to roll out at the same time, because we really want to help our patients in this community and keep our money here.
And do you think you see much change in the percentage of people that are self-pay that you're seeing?
Not so much. I think that there's quite a few people that don't qualify for Medicaid anymore.
or they don't know how to get that through. And so our goal is to try and help them, be that outreach for them, to let them know that we're here for them. We don't want them to not have services.
Right.
But we also want to let them know that if they need help applying, or here's, we're here to help them at the same time. But we're still seeing about the same ratio.
Okay.
Nothing's really changed because you can't sign up right now unless you have a life-altering event, right?
Right.
So unless you have a child or you go through a divorce or, yeah.
Okay.
So, other than that, we are seeing, even as of today, that United Medicare Advantage has dropped Wyoming. It's a Medicare Advantage program that they're just not servicing Wyoming anymore. And that's another thing that we just have to monitor really closely. We need to get that information out to our patients so that they don't select that plan, so that they're not going to get billed for services that they're receiving. And so that's just going to be something that we'll continue to monitor at the same time.
Another question are there any kind of programs with like foundations or anything that's ever been looked at? It's like what I'm thinking is a friend that ended up, it was a hospital in Rapid, but when he went to the hospital from an accident, he thought he was injured, but when he got there, they found out, both of the victims, that they didn't, with yours, and it's who I'm talking about, with Eric, when the accident happened, and that he wasn't injured, but the hospital had programs in place that pretty much paid all of his from outside sources, that had been donated. Is there anything that we've looked at in along those lines?
About the BOSS program, or Paul, can you talk about the BOSS program?
I'm going to yield to you and let you explain the BOSS
No,
program.
don't yield now. Go ahead. Kick it off. You got this. Send it. Don't yield now. Go ahead. Send it.
So we have been in negotiations with our credit collection company, and they have a program that's called the BOSS program. And the BOSS program is basically that we pay a lower rate for the first 90 days. We send the accounts over there. They're going to be working with our financial assistants, screening our patients, being able to see whether or not they qualify for financial assistance. If they do, we'll send them to the online assistance. But what it's going to do is it's going to allow us to get that money collected faster. It will also allow the people to set up payment arrangements if they qualify for it. It's just going to be a really good touch base all the way around. They're going to be making all of our outside calls for us. This is also why we're going to be turning on our text messages and then the email alerts at the same time. As far as donation of money, one of the things is that you have to understand too is that they didn't have auto insurance. You can always run that claim through your homeowner's insurance. So that's also something that if you don't work in the insurance field, you really don't know that that's available to you. And so that's what we're hoping to bring to awareness to all of our community, is that if you own a home, you can run an accident that happens on your ranch, your farm, any of that stuff through your homeowners at the same time. So our goal eventually is to make sure that we are providing and doing that full transparency at the time. So anything that comes in for radiology, Epic has the ability that once we put in that order, it will check their insurance. It will tell them exactly what their out-of-pocket expense is, how much their insurance is going to be paying, so that we can start to collect that money. It will actually save us a lot of money, so we're not sending waiting for it. We're not sending the statement. We're not spending energy. We can even offer, depending on what we come up with, the financial assistance, offering a prompt pay right then, write us a check. It'll save money all the way around. And I think it's going to be a really good patient satisfier in the end, because they're going to be able to make that choice whether or not they feel like they can afford it. And hopefully if they want to do 3 payments, we collect that first payment up front. That's also an acknowledgement that they owe that debt.
So just want to clarify, all true, just to clarify. So right now, what we've outsourced to Inova is our patient bills that go out to payers, Blue Cross, Aetna, Medicare, Medicaid. Then there's the self-pay portion that really falls to us to collect. And that's not uncommon in many organizations that outsource. So rather than our hire people on for the self-pay and do that tracking, The BOSS program is a company that specializes in managing and billing and collecting self-pay accounts. So as Trissa said, the fresher they get the accounts after discharge or service, the better. And we would pay them a lesser percentage fee of collections than those that are 90 days out or 120. That being said, we are adding a patient authorization rep, certification rep here locally on site to be the sharpshooter for trying to squeeze out every potential way of getting paid through homeowners, through this, through that. But he or she, when can't find anything and it goes to the BOSS program, they are better sharpshooters in looking through foundation funds elsewhere, other kinds of services to be able to help patients get their bills paid.
See, I thought that we turned over self-pay to,
We
Age.
talked about it and we had a proposal from Inova, but we never pulled the trigger on it. I thought the same thing too. I thought they were doing part of it, but we had never pulled the trigger on it. So essentially right now, but what the BOSS program is BOSS means Business Office Support Services. And basically that's what they're doing. They're making sure that the phone calls from the patients get answered quickly and promptly, that there's follow-up on that. It's just a supplement to our staff. And I just learned about it from you guys and I think it's wonderful.
Yeah, and
it's going to really help us.
And Trissa, help me. We're engaged with them now for older accounts, right?
They're already our credit.
They're already our credit collection company, and we're adding this piece. And the piece that I like about it too, besides they have the people to answer the calls and be present, I like that they are paid when we're paid.
well, I guess it looks a lot different to me now knowing that wasn't turned over. Because I've been waiting to see improvements in that area. But if it was never turned over, now it makes sense why we've been sluggish. And
So the self-pay and we've had a lot of talks about that too, about breaking the accounts receivable out into the insurance portion and the private pay, self-pay portion, because it's very different in how you collect it, how quickly you collect it. They're two different animals. And I know that would help me to really understand it more. And I think sensing from your question, that would really help a lot of us, the whole board, and the whole process, because they're different. So collecting from an insurance company is very different from collecting from the patients. And it's a different skill set. And I think this program is really going to supplement the people that we have. And we've heard from the community for years that we need to do better with providing their information to them. So I'm hoping that this is going to be a real step in that direction. Just to supplement on to what Trissa said, Trissa's been doing a great job with working with Inova to identify areas where we can collect money that's owed to us. One of the things that Trissa identified this week that really hammered home for me, this is a long-term problem. This has been going on for a very long time here in this organization. It didn't just happen overnight. It didn't just happen with Inova. Trissa found a bucket this week that is from 2023. And it's been just sitting there and no one's ever worked it, and there's a problem with it and no one ever solved it. So this is, I know it feels like it should go faster, but this is a deep problem here. Paul will tell you a little bit about the fact that our Epic was never really built correctly, which is part of the problem that we're having with billing. And all that needs to be rebuilt from the ground. And the team here is really jumping in and doing that. There's a lot of progress that's being made, but the problem didn't get here overnight, and it's not going to be solved overnight, but
Yeah, if moderate Republicans are their dislike for Freedom Caucus is enough that they'll actually vote for a Democrat. I mean, there is that potential.
Yeah, it's just because to me, you know, and I watch all of these public meetings, and you don't see the moderates at the meetings.
No.
You don't see those people that sit on the middle of the fence at the meetings. They're not passionate enough about anything to show up to the meetings, to stand on a podium and say something. You have to be extremely passionate about politics to be willing to put yourself out there and to be judged in that sense. And I don't think you see the people that ride the middle of the fence doing that because they ride the middle of the fence. So they're like, I really don't care either way. It doesn't impact my life directly. I'm not planning on getting an abortion. So why do I care about what the abortion law is? Like, I don't own a bunch of land, so property tax doesn't hurt my feelings. Like, I think there's a lot of those people, the young people in Wyoming.
I feel like we're farther along the path of solving this problem than we ever have been, as long as I've been on the board.
One of the benefits of the BOSS program, just so you're aware, is if they make an out call and the patient says, well, I never received a statement. First thing is they're intertwined with our Epic, so they're going to be able to say, verify your address. We can see exactly how many statements were sent, how they were delivered. They will also be able to say, yes, your insurance was billed. This is who was billed. This is what was paid. And so there's not going to be that back and forth where they're going to be sending accounts to us to research. We're going to be able to have that front line. They're all right here. They're out of North Dakota. They're all, you can understand them, not to be rude, but you can understand what they're talking about.
What's our timeline for signing?
Timeline for signing, we're just waiting. Paul's been kind of sharpening that pencil.
By mid-July, will be implemented.
I'm hoping by the 30th.
And the other, that's gonna be in conjunction. We're also getting ways for patients to be able to pay easier too. So like for instance, I'll just give you my own personal, that I ended up in the emergency room, like 3 months ago, I told you. And I knew I had a $35 copay. I got several texts, but you can't pay your $35 copay with a text. And so it took a while to get the insurance company payment and then to post the payment. And then, so it literally took 3 months before I got a bill for $35 and I ran down here the next day. But you know, that's the kind of thing that's hard on patients and that this program's really going to help with, to get those bills out sooner, so that patients know exactly where they stand. So.
What's the percentage that collection agency gets?
Right now in the BOSS program, or just in general?
In NOVA.
Paul, what is that percentage that the collection agency is getting besides the BOSS program?
On the collection agency, it depends on the timeline, but it's as high as 25% and low as 18.2%.
Thanks.
That's for old collection.
That's for old stuff. Are you asking for?
No, I'm just asking
for old
stuff.
Okay.
That's good.
Thank you.
It's not bad, actually.
Thank you.
Okay, any other questions for revenue? Okay. Rebecca, you're up.
Well, good evening. So HR obviously is continuing to support the stabilization plan. However, recruitment is number one. Dawn, the HR generalist that works for me, I guess I should say works with me. That's the more appropriate thing, but she loves recruitment. She's pretty outgoing. So she's been, researching what she can do to help with recruitment. We had a stumbling block with the Gillette recruitment fairs that were supposed to be happening, but we're not letting that stop us. Next week we're gonna go and see where she can travel to, set up some things maybe in Custer. So we're brainstorming on that. We had a successful one on June 2nd. Was it a massive turnout? No, but it's our first one. So now we've all learned as a team what we need to improve on, what we can change. But we did, I think, get 2 hires out of it.
Hired 2.
But I think we got a student for the CNA program out of that. So that is a future employee. So that was good. Paul and I already look into 2027 for benefit planning. As you know, we want to move away from this self-funded plan if possible. So he's looking at the finances and the data, and I'm looking at the employee side and what we can be competitive with. And my ultimate goal is that by the end of the year, we have a very smooth open enrollment and a benefit fair for all our employees where vendors show. So I'm excited about that. And last but not least, don't stop thinking about iSolve because it's coming back. We're just a little busy with other things, but it is very much coming back. And as we discussed before, this team has all participated in the demo, and we're all feeling that it's going to meet the needs of the organization. And you should expect an ROI from us. So, and then I obviously include the positions. There are some notes that I even had to make because we did onboards today. So, and we did put an offer out for Donalda's position a couple hours ago. The acute care CNA for the night shift.
Not Donalda's position.
How can I turn around and be polite anymore?
Panic too.
Any questions for me?
All right, thank you.
And to add, I forgot to add, I apologize, that you're going to hear more from Pat about the incentives that Kim touched on. And so I won't bore you with that. So.
All right, thank you, Rebecca. Donalda, acute care.
So this is acute care, but it should also include emergency room and EBS department. So today, the current census is 4 patients. We have 2 skilled swing beds and 2 acute care patients. Our admissions in May, we had 16 inpatients, 15 observation, 9 skilled swing bed, and 4 intermediates. That is an improvement. In May, we only had 3 skilled swing beds and 8 inpatients. So our plan is working. The referrals are mostly coming still from Monument Health in Campbell County. We did have one from the VA, but he chose to stay there at the VA with his regular doctors and nurses. The emergency room saw 199 patients, and that's an increase of almost 50 patients compared to May, which was 151. And it's, you know, summer's here, people are doing outdoor activities, getting a few more injuries that way. And we have had a couple traumas related to side-by-side accidents this summer already. So those things keep us hopping. For staffing, I currently still have 1 contract CNA, but as Rebecca mentioned, we interviewed and hired a full-time CNA for that position. We'll just keep that contract CNA until we get her trained and on the floor and feeling comfortable. We're also recruiting for a full-time RN LPN, and we're working on onboarding Dr. Fairbanks. He worked with us before. He was a locum, I don't even know, like 10 years ago. And he's kind of filling in the gaps since Dr. Franklin's backed off a little bit. He's went from 8 shifts a month to down to 4. So we had to have and it'll be good to have another physician. Not that mid-levels are any worse off, but it's just nice for the community to hear that we have another doctor.
And he's not locum, he's contracting with us or becoming our employee.
He's locum now.
No.
He used to be.
He was
like 10 years ago locum, but he's gonna hire on as PRN. So he'll be our employee.
So where's he from?
He actually resides in Shell, Wyoming. But he's worked all over the place. So, sounds like he's a busy guy, jumping from place to place. His first shift will be July 5th in the emergency room. Yep. For EBS, we started a staggered shift. Normally the EBS department all work 5 a.m. to 1:30. So this person will work from 10 in the morning till 6:30 in the evening, just kind of picking up those late discharges on the hospital side, helping with any extra things that come up in those after hours. they'll assist the dietary department with cleaning up the evening meal, kind of get the dining room set up for the breakfast. And then they're restocking clothing protectors in a new cabinet we have in the dining room over at the Manor for residents. And that just kind of helps the CNAs from going all the way down the hall to get their clothing protectors and bring them for the residents. So it's just nice that we can help them. The quality projects I'm working on still are the discharge vital signs, still just about 75% of the time they're getting those done. Laundry has started a project to monitor their dirty laundry placed in the carts, and that is, I haven't seen anything on their form this month that the CNAs are not using bagged laundry, bags for laundry and things like that. So that's improving. And then I started monitoring the housekeeping carts for labels on their bottles with chemicals. OSHA regulations say that all bottles need to be marked, and it should list what the product is, the potential dangers if you have an exposure, and then the first aid that's required if you do get exposed, like somebody accidentally drinks something. Medication scanning by the nursing staff in May was 86%, down from 94 in April. But that was due to a end-of-life medication that the nurses had nothing to scan for, so they had to override that medication. Month to date in June, our scanning percentage is 92, so the nurses are working really well with that. They're utilizing the computers on wheels in the emergency room and in the inpatient areas. Barcode scanning is an important safety feature for nursing to prevent medication errors. If you give a patient the wrong medication, the wrong dose, even giving a medication to the wrong patient, that can cause some problems. My stabilization update. The goal of increasing acute care inpatient and skilled swing bed admission continues to make progress, as we can see from our numbers. And I'm still doing the call with Monument Health every morning just to give them my census, my bed availability, and they also give me their census. So we know they're on divert, they're holding patients, their behavioral health beds, things like that. So Charlotte, Pat, and I traveled to Campbell County to meet with their CEO and their administration team and their discharge planners, and I got to meet the people that I've been talking to for the last couple of years. And so it was nice to shake hands with them, and now I have a face to put with the name. Pat and their CEO visited about many issues that that'll benefit our facility. So Kelly Page, our discharge planner, is fitting well into the role of swing bed coordinator. We're working together to get her known to the discharge planners from the other places, getting those patients here in the 2-hour time. It's driving for. The only delay in admission usually is just insurance pre-authorization. So, and then Charlotte has worked on a patient testimonial that you should all see soon. A patient that came into our emergency room, went to Rapid City, came back as a skilled swing bed, and then is also utilizing that. So he went through all of the things, and he was very appreciative. So,
and all just being shy, so let me brag better. The patient came into the ED with a dissecting aortic aneurysm. And our radiology staff with the ED nursing staff were able to get him into imaging very quickly, establish that, I think he went to Monument, but stabilize him, and he went and had surgery. He did have a mini stroke, but what a story that he then came back, and as she said, came back to our swing bed program. Home Health is now has him in her hands, and he agreed to a case study And Charlotte interviewed him, and we're going to put a picture to it. It'll be on our website and Facebook and distribute to the community. We need to put more stories out there on these kind of scenarios that we do deal with and educate folks.
Great.
Questions?
Well, I would like to say, on a personal note, my wife was in the ER twice earlier this month with a dog bite, and the staff was wonderful. They did a great job. So,
It's always good to hear.
yeah, and I greatly appreciate the work they did. Any other questions, comments for Canalda? All right.
You didn't stick your dog on that.
No, it was a neighbor's dog. It wasn't the dog's fault either. I won't go to the story. So, finance.
Hey,
You're up.
how's it going, everyone? Give me 1 second to pop this open for you. All right. Let me know if everyone can see my screen here. Good?
No.
We can see, but
You're gonna have to get a bigger TV.
All right. Well, we have people online too, right? So I can make it bigger, and Emma might be able to grab. Sorry.
I haven't yet begun to whine.
Okay. So for this period, we did 2.498 million, which is roughly 1.9 off of budget, 1.9% off of budget. However, if you look at the period over period, month over month, we're actually 1% higher.
When life gets tough, you don't have to face it alone. Call 988 for confidential, free support 24/7.
Just to give a little context, that was primarily driven by very nominal increases in volume over at the ED, and I believe swing bet as well. If you look at our revenue deductions, this is where it gets interesting. As Trissa was mentioning earlier, we are trying to work through some of those age claims. And because they're in these work queues that have been sitting out there for a long time, we are experiencing a lot of denials out of that program. And essentially, because they're aged out, there's no way for us to actually, and Trissa, correct me if I'm wrong here, but there's no way for us to actually collect on those claims once they've aged.
When they
So-
just, there's nothing else that we can do for them. They can go for an appeal, but they have to be filed in a timely manner.
So that's where you're seeing an increase there. Other operating revenue was mostly flat, however, was down 15% month over month, but still pretty strong. Regardless, it's pretty normal across the period, so we expect it to float or oscillate around that 400K, 430K. And so with that, we had a result of 1.986 million for the period. Again, it's a little short of the previous period. And again, that's primarily driven by those revenue deductions. So if we adjust for those revenue deductions, the increase was, I believe, 540,000 or 440,000 across the period. And if we adjust for that piece, you'll see kind of a normalized result. Sorry, I blanked there for a second. Normalized result. It'd be much closer to the previous period in April. Any questions on that? Perfect.
No.
For total operating expense for the period, 2.2 million. That is slightly higher than the previous period. A lot of that's driven by the fact that we had some renewals of long-term contracts this period. Naturally, we had that increase. The final result for the period was that negative operating profit net or loss, negative 221,399. Again, that's strictly operating revenue minus operating expenses for the period. It does not take into account anything below that line for that non-operating income, interest income, so on and so forth. For the non-operating income, what you'll see here is a stark difference between the previous period and the current period from April to May. In the previous period, in April, that 600K plus increase was primarily driven by us receiving back our outstanding mill levy money from the county. They were able to release that to us because we were able to come to an agreement with the DOA to get our documents in on time. And that hit for that month right now. However, what's important to note is that we do have to spread that amount out across the periods in which it was incurred. So right now you see April 30th has 625K on that line item. What will happen is we will then kind of bifurcate that out across each period in which we should have received that amount. And that will normalize the final financial picture for that period, if that makes sense. And let me know if you want me to dive deeper into any of this. Happy to disaggregate.
Thanks.
Perfect. And so the total net income and loss, it was, again, primarily driven, this negative number is primarily driven by that increase in total revenue deductions. The negative 193,948 for the period should really be roughly 430,000 for the period if you adjust and normalize for that total revenue deductions piece. And again, that's primarily driven by disciplined spending on the staff's part. Huge kudos to the staff. We're doing a lot of great things there with spending. And then also Trissa's great work in clearing out those old accounts. So we'll see some of these increased amounts in those total revenue deductions until the job is done. But that's just a natural occurrence of kind of cleaning out the closet and making things right again, if that makes sense. So any questions on this before we move on to the balance sheet and statement of cash flows?
Everybody, Paul, keep going.
Yes, sir. Perfect. Okay. So for this month here, far right column on the balance sheet, and let me know if this needs to go in a little bit, I can do that. We're looking at a decrease in cash for roughly 1.6 million. And I'll get to that in here in a second. It'll make a lot of sense. We did have an increase of 158K in accounts receivable. What we noticed, and a lot of credit to Trissa on this, what we noticed was that because we found so much work that hasn't been done stuck in these work queues, we found that our RCM company was essentially kind of bifurcating their efforts between kind of two separate efforts, if you will. They kind of split the old and the new incoming workflows between the team. And so some of that is attributed to kind of that bifurcation. We've since discussed this with our third-party RCM team, and they have kind of blended workflows at this point, so we shouldn't see that on the go forward. However, there's always going to be perhaps a little bit of accounts receivable at this point until we totally fix everything that's going on in RCM with respect to everything we have on the Epic side, as well as anything we want to do work process improvement wise. Any questions on that so far? No?
Doesn't look like. Nope.
Okay. So that's the increase in the accounts receivable for that 139K. Sorry, I'm trying to find my mouse to scroll down. There we go. We did have that decrease in the current liabilities of the 972K. Now, heavy AP month last month, when we think about catching up to all the aged AP that was outstanding, the team came together, had an honest conversation about where we were at in the aged AP. We then took a step back and said, okay, let's just extinguish as much of this as we can. And so we tackled it really hard this past month, putting the capital that came in through the mill levy to good use and kind of planned out how we were to attack it. So most of the, call it 90 to 120 day HAP is paid off. I believe we have a small chunk left. I think it's 23% of the total is left. And we'll continue to pay all of that off over time. We're about to that point. I think I said in previous board meetings, and please fact check me, I think I said like August, September timeframe, we should see a normalization of AP, and we'd be around that 30 to 60 to 90 day timeframe. And we're just on the cusp of that at this point on the AP. When we think about, sorry.
Very good.
Okay. When we think about the total liabilities for the period, we did decrease that 983,192, and that's a really good thing for the organization. That lightens the load extremely well for us. And as we continue to implement this disciplined spending and reduction of AP, we should continue to see great returns to cash flows, right? Because we're not actually spending as much out each month. And if you think about the previous comments that I've made, we were actually netting, I think, $100,000 month over month in positive AP growth. So we were, as much as we were spending to spend it down and decrease the AP amount outstanding, we were still accruing that $100,000. And I think when we look at this month, we actually had a savings. So that's kudos to the team and kudos to the leadership for doing the right things at the ground level and making sure that their spending was correct. And we will always have some of these larger contract renewals that we sell for the period. But once again, those things are amortized on the balance sheet across their useful life. It is an expense in the period. Excuse me. It is an expense in the period. However, those are the things that it takes to run the hospital. So we have to, unfortunately, do them as they come along. Any questions on that? Perfect.
Nope.
So for the cash flow statement, we did have that net loss for the period of $195,438. This is our normalized D&A amount right here. As part of the new budget, we are going to be updating this 104,023 to reflect the new amount of capital that we have, or plant, property, and equipment, excuse me, that we have in the facility. So that amount will adjust, but we'll see that on the end of year financials and the go forward. So in the accounts receivable period, like I said, we did have that 139,068 as a more AR, less cash scenario. But once again, this will fluctuate, and a large part of this is driven by what we're seeing in the work queues. Our allowance for doubtful accounts, we did have a decrease, which is good. So I believe we realized 21,883 through CCB during the period. So that's that credit collection agency that partners with the BOSS program to run our people through the process of figuring out what financial solution works best for them. They actually were able to collect 21,883 of outstanding capital for the period, so that was great. We did have a change in inventory. Now, what's important here is that all these other numbers, like the first one, is negative, and that's not great because that means our cash wasn't as much as our AR didn't overcome it, right? So that's not the greatest thing in the world because now we have 139K of IOUs. But what's interesting is this change in allowance for doubtful accounts. That negative is a positive thing when you think about the balance sheet. But then you go to the inventory. Now that's a positive number. Did we spend or did we use? And this means that we use the current inventory that's in our inventory system now for a positive $1,241. We think of it as a use of cash for the system. And so that's a positive outcome, right? You want to use the inventory that you have internally to be able to facilitate operations. Just a little tidbit of accounting there for you. So for the result, we did lose that 1.486, mainly driven by that accounts payable change in the period there. Net cash provided by investing activities, we did have that 19,445. 14K of that was to our special revenue bond fund that we have a sinking fund for the bond. It was 14,553. Some interest on top of that there, and totaling out to the 19,400. I'm sorry, not interest, fees, totaling out to the 19,455. Now on the next line, that's the interest line. we did pay a little bit of interest during the period of $2,702. Our net increase or decrease in cash for the period is that 1.508. The cash at the beginning of the period was that 1.787, again, largely driven by that check that we received for the mill levy funds. Cash at end of period, when you subtract the two, is that 278,496. And again, we did have a very, very large AP run during the period and a lot of renewals. So that is a large amount of reduction in cash, but it had to happen to make sure that we were meeting our obligations on the financial side.
So Paul, just to reiterate the AP is going to start balancing out where we're not going to see so much. We're catching up, in other words.
That's exactly right. So we had a very large reduction in the largest aging AP. I think it was 400,000, right around there. Those accounts had to be taken care of at this point, right? So we made the push there. And as we kind of enter into the next few months, my assumption is somewhere around August to October is where we're going to start hitting that 30 to 60, 60 to 90 day AP timeframe. And like I said, right now we have the 120 line, if you will, or column left to take care of. And I think there's about 23% of our total AP outstanding falls into that category.
So I think it was maybe a board meeting or two ago, and you were still chair and asked what our outstanding accounts payable was. Yeah, I figured you had your little notes. It was a little over 3 million or close to 3 million, correct? Mm-hmm. I had to cut Ann off at the pass. I knew where she was going. And
I was going to announce it.
Oh, okay. Oh, okay. You were going to do it. And now we're 3.8. And now we're what, Paul?
1.4.
Like 1.4. Yeah, 1.4 as kind of this time frame right now. So it's been a remarkable shift on that side.
So if you add the revolver and the board restricted money that is owed and then the accounts payable, it's only 1.4?
That's correct. Well, the revolver is a little different. I want to caveat the revolver for a second. Let's hold that. But the board restricted payment, are you saying to repay the 500K? Okay. Yeah. No, that's a different kind of section there. What we're talking about now is adjusted AP, and I'm happy to get you that number. But for what the AP, operational AP, think about it like that. What that AP looked like was much larger. And so if you adjust that, we're at around 1.4 or so right now. As of this sheet here, I believe it was 1.57. We've obviously paid more since the last month. So we're about 1.4 at this point. That's that figure there.
I think Ann's trying to do apples to apples. I think the 3.8 may have involved what we owed on the credit line.
It did.
The revolver.
Yeah, it did.
Okay.
So that's 1.8. It included what we owed on the revolver.
If we do your apples to apples, we're at 1.9 instead of 1.4.
Correct.
That's still really exciting.
Yes.
And
our AP owed is down from 180 days to approximately 60. So that's really
with some hangouts, but we're going to clean that up. Yeah.
Great.
Excellent. Keep going, Paul.
Yes, sir. So I like to flash this for the team here, and let me zoom out so you can see everything.